An anonymous patient arrives in the ICU. They are presenting simultaneously with severe status epilepticus, septic shock, and a completely unknown home medication list. The immediate diagnostic data demands intervention. Look at this ECG tracing. It shows an irregular, narrow complex arrhythmia lacking P waves. This is atrial fibrillation with a rapid ventricular response, compounding the existing shock and causing blood pressure to collapse. In a multi-system crisis, the standard clinical instinct is to rely on protocol-driven algorithms. You start standard infusions and escalate the doses proportionally, expecting a linear physiological response to regain control of the patient's vitals. This instinct relies on foundational drug loading mathematics. Volume of distribution equals dose divided by initial concentration. Clearance equals the elimination rate constant multiplied by that volume. Notice the clearance variable. Algorithms assume this is a constant fraction. Double the dose, and clearance scales proportionally. In severe critical care polypharmacy, that assumption fails. Metabolic pathways and transport proteins have hard physical limits. Once drug concentrations cross these thresholds, clearance is no longer a constant fraction. We are going to map the choice architecture of critical care pharmacology. To treat a patient at the edge of viability, we have to track variables from microscopic biochemical constants up to systemic hemodynamic reflexes. Failing to recognize the boundary between linear scaling and metabolic saturation turns standard protocol-driven care into a direct cause of lethal iatrogenic toxicity. This graph plots time against plasma drug concentration, illustrating first-order kinetics with a constant half-life. But the liver has limited enzymes, creating a hard limit. When concentration exceeds the ceiling, the system shifts to zero-order kinetics. A constant amount is eliminated over time, making the half-life variable. This changes how we calculate interventions. A loading dose is designed to reach a target steady-state concentration. It relies strictly on the volume of distribution and the drug's bioavailability. It does not depend on clearance. A maintenance dose is entirely different. This equation shows that maintaining a steady state requires calculating the dosing interval and the clearance. Returning to our patient in status epilepticus, their phenytoin levels are subtherapeutic. The standard reflex is to push the maintenance dose higher. Phenytoin has a notoriously narrow therapeutic index. Its metabolic pathways saturate at levels extremely close to the therapeutic target, causing a rapid shift from first-order to zero-order kinetics. Once that enzymatic ceiling is hit, the liver cannot clear the drug any faster. Pushing the dose slightly beyond this threshold triggers sudden systemic accumulation. Attempting proportional, linear dose adjustments past the saturation boundary mathematically guarantees neurotoxicity and systemic failure. To understand why clearance rates fluctuate, we must move from macroscopic graphs down to the liver's endoplasmic reticulum, specifically the cytochrome P450 network. The CYP450 system is responsible for metabolizing the vast majority of maintenance ICU medications. Its baseline function is to systematically oxidize drug molecules for renal excretion. This matrix maps specific drug interactions. Introducing CYP inhibitors like amiodarone blocks enzyme active sites, acutely spiking substrate levels of co-administered drugs and precipitating toxicity. Conversely, CYP inducers like rifampin force the liver to synthesize more enzymes, accelerating clearance and destroying therapeutic trough levels. This network is further complicated by genetic polymorphisms. A patient may express the CYP2D6 ultra-rapid metabolizer phenotype, meaning their baseline enzymatic capacity far exceeds the population average. If an ultra-rapid metabolizer receives standard coding, the enzyme converts it into morphine rapidly. This bypasses clearance expectations and causes sudden, life-threatening respiratory depression. Metabolism isn't the only variable. Cellular defense mechanisms dictate distribution. This schematic illustrates the P-glycoprotein efflux pump actively ejecting specific molecules from the CNS back into circulation. If an inhibitor, like verapamil, PAMs the pump, concurrently administered drugs like digoxin rapidly accumulate inside the central nervous system. Unmapped enzymatic inhibition and efflux blockades weaponize standard maintenance doses. They turn necessary co-administrations into lethal traps. Let's pivot back to our patient's septic shock. The The dropping blood pressure requires rapid hemodynamic stabilization using vasoactive infusions. Vasopressors rely on three primary G protein cascades. The GQ cascade activates alpha-1 receptors, forcing massive vasoconstriction. The GS cascade activates beta-1 receptors, increasing CANP to drive up cardiac contractility. Conversely, the GI cascade activates M2 receptors, which physically inhibits adenylyl cyclase, slowing the heart. In septic shock, a clinician might choose to infuse a pure alpha-1 agonist like phenylephrine. The goal is to spike systemic vascular resistance and restore mean arterial pressure. This initiates a physiologic reflex trap. The sudden artificial spike in arterial pressure stretches the aorta and triggers the aortic arch baroreceptors. The activation of these baroreceptors sends a signal to the brainstem, which fires high vagal tone directly to the heart. This engages those GI-coupled M2 receptors. The adenylyl cyclase is inhibited, resulting in a severe iatrogenic reflex bradycardia. This reflex can be bypassed. Utilizing epinephrine, a mixed agonist, or isoproterenol, a pure beta agonist, directly stimulates the GS pathway, chemically overriding the GI reflex loop. Utilizing isolated receptor agonists without calculating the coupled autonomic reflex loops creates predictable mechanical hemodynamic crashes. We return to the bedside of our multisystem failure patient. The concurrent crises are reconciled by mapping the exact constraints of their physiology. Look at the monitor now. The heart rate has stabilized to 60 beats per minute in a normal sinus rhythm. We sequence the interventions to respect the underlying hemodynamics, allowing the heart to recover its pacing. We calculated the true steady-state concentration of phenytoin, factoring in its shift to zero-order elimination. By mapping that boundary, we adjusted the dose properly and prevented runaway neurotoxicity. We checked the CYP network before starting shock therapies, ensuring the selected vasoactive drips would not inhibit or induce the clearance of the patient's critical antiepileptic medications. To understand how high the stakes are when these principles are ignored, consider the cocaine toxidrome. Cocaine causes profound mixed alpha and beta stimulation. If a clinician sees the resulting tachycardia and chooses to administer a pure beta blocker, they are making a fatal error. This visual equation shows the outcome. By blocking only the beta receptors, you leave the alpha-1 signaling completely unopposed. The GQ pathway fires with nothing to balance it. The result is runaway vasoconstriction, leading directly to a devastating hypertensive crisis and stroke. Safely de-escalating this toxidrome requires utilizing mixed alpha and beta antagonists, or pure vasodilators, bringing both sides of the autonomic system down evenly. True critical care requires abandoning memorized algorithms the moment physiological thresholds are breached. From identifying Michaelis-Menten kinetics to calculating GPCR reflexes, mastering the choice architecture is the ultimate requirement for surviving the high-stakes environment of ICU pharmacology.